Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this part 2 module of menopause, we are going to discuss about a very important condition which is called as osteoporosis. So osteoporosis is a very important condition in your pharmacology, in orthopedics and in gynecology as well. So in this module, we'll be dealing about how osteoporosis and menopause is interlinked to each other and what is the actual pathology which is happening in osteoporosis and what are the treatment modalities which are available to us in the treatment of osteoporosis in a menopausal age group female. So before discussing about osteoporosis, let's start with the basics of osteoporosis. So I'm going to introduce a new term to you now, which is called as bone remodeling. So bone remodeling is basically a physiological process which happens in every single person, where bone remodeling means the old bone is going to be removed and it is going to be replaced with the new bone. So basically what is happening is whatever damage is present in the bone, this damage is going to be removed and the new bone formation is going to maintain the bone strength. So bone remodeling is a process where the old bone is going to be removed and the new bone is going to be formed. So this process is actually facilitated with the help of two important groups of cells which are called as the osteoblast and the osteoclast. So what are osteoblasts? So osteoblasts are the groups of cells which will help in bone formation. So osteoblast will result in formation of bone through the formation of collagen matrix and it will result in formation of new bone. Whereas the major function of osteoclast is to break down the bone tissues and it is going to result in release of the bone minerals inside the patient's blood or the serum. So since all the bone minerals are going to be lost from the bone and it is released in the serum, therefore the bone mineral density of that particular bone is going to be decreased and that particular bone is going to be replaced with the formation of new bone matrix which is facilitated with the help of osteoblast. So osteoclast is going to remove the bone, remove the damaged bone, and osteoblast is going to form new bone and replace it with the old damaged bone. So this is the basic of bone remodeling. So this is actually a physiological phenomenon which happens in every single person. But if this is going to occur in an excessive manner, if this bone remodeling happens in an excessive manner, it is going to result in osteoporosis. Because when the bone remodeling is going to happen in a hastened manner, in excessive manner, it is going to result in loss of the bone mineral density. So once the bone is going to be devoid of all the bone minerals, the bone is actually going to become weak and lose its strength. So this is called as the osteoporosis. So we are going to break down this term osteoporosis into two halves. So osteo stands for bone and porosis stands for the porous nature of the bone. Why it is called as porous nature? Because since the bone has lost its bone mineral density, it is going to have some trenches, some pits in the bone, which is compared to the porous nature of a rock. So the bone, which is actually a hard structure, is going to become like a porous material which is compared to the porous nature of a rock. So since the bone is going to become porous in nature, it is called as osteoporosis. Is that clear? Yes, fine. So since the problem is actually with the quality of the bone, it is a qualitative defect. So osteoporosis is a qualitative defect and it is not a quantitative defect. Is that clear until now? Yes. I hope it is very clear until now. Okay. So now let's discuss about how resorption of the bone happens. So resorption of the bone happens with the starting point being the osteoblast. So osteoblasts, which are the bone forming cells, are going to form a polypeptide protein which is called as a rank ligand. So this rank ligand, which is a polypeptide protein, is going to bind to certain receptors which are present on the osteoclast. Is that clear? Osteoblasts, which are the bone forming cells, are going to form the rank ligand, which are a polypeptide protein. So this rank ligand is going to bind to the receptors which are present on the surface of the osteoclast, which are the bone resorption cells. Is that clear? Yes. So since it is going to bind to the receptors of the osteoclast, it is going to result in stimulation of the osteoclast. So since the osteoclast is getting stimulated, the major function of the osteoclast is to break down the bone tissue, which is going to result in loss of all the bone minerals into the patient's serum, and this will result in loss of the bone mineral density. So once the bone minerals are going to be lost from the bone, which is called as the resorption of the bone, therefore since the bone minerals are released in the serum, it is going to result in increased amount of serum calcium, but at the same time the bone which has lost its mineral, it is going to become very weak. So since it has become weak, it is called as osteoporosis, where the hard structure of the bone is now turned into a porous structure. The bone has lost its strength, it has become weak, and this bone is vulnerable to high risk of fracture. There is high risk of fracture in these osteoporotic bones. Is that clear until now? So let me just give you a hint again. So osteoblast will form the rank ligand. This rank ligand, which is a polypeptide protein, will bind to certain receptors which are present on the surface of osteoclast, and this osteoclast is going to get stimulated, and the main function of the osteoclast is to result in resorption of the bone. So since the bone is going to result in loss of all the bone minerals will be released in the serum of the patient. Therefore, there is going to be increase in amount of serum calcium, but at the same time, the bone is going to become weak, and this bone is at increased risk of fractures. So this is called as osteoporosis. So this is how bone remodeling is going to happen. Is that clear? Yes. But this phenomenon of osteoporosis is going to happen only in a menopausal age group female. Why? Because is that in menopausal age group female, there is decreased amount of estrogen. You just remember this one point. In menopausal age group female, there is decreased amount of estrogen. Okay, but in reproductive age group female and in adolescent, reproductive and perimenopausal age group female, estrogen hormone is going to be present. If estrogen is present, estrogen is going to produce a protein which is called as osteoprotein protein. OPG, osteoprotein protein. The major function of this osteoprotein protein is that it is going to bind to the rank ligands which are formed by the osteoblast. So we saw that osteoblast is going to form rank ligand, but I'm saying here that estrogen is going to produce a particular protein which is called as osteoprotein protein, which is OPG. This OPG is going to bind to this rank ligand. So since this OPG is going to bind to the rank ligand, therefore this rank ligand cannot bind to the receptors which are present on the surface of osteoclast, and it will never result in the stimulation of osteoclast. If the osteoclast is not getting stimulated, therefore the resorption of the bone can never happen. If the resorption of the bone is going to never happen, therefore osteoporosis is not going to happen. So now you tell me, estrogen is a very golden hormone which is going to prevent a female from osteoporosis. But when? During the reproductive age group and during the perimenopausal age group. Why? Because is that in reproductive as well as in perimenopausal age group female, there are estrogen hormone being present in that patient. But in menopausal age group female, there is decreased amount of estrogen. So the major part here is that since estrogen is present in higher amount in reproductive age group female, this estrogen will form osteoprotein protein, and this protein is going to bind to the rank ligand, and it will prevent the stimulation of the osteoclast, and it will prevent the process of resorption of the bone, and it will never result in osteoporosis. So the major hormone here is estrogen. But in menopausal age group female, there is a decreased amount of estrogen. If there is going to be decreased amount of estrogen, definitely there is going to be decreased amount of osteoprotein protein. If there is decreased amount of osteoprotein protein, this osteoprotein protein can never bind to the rank ligand. So therefore, this rank ligand is going to bind to the receptors which are situated on the surface of the osteoclast, and it will result in stimulation of the osteoclast and resorption of the bone, where the bone mineral density is actually going to get decreased, and since the bone is going to become weak, it is at high risk of fractures. So it is at increased risk of fractures. Is that clear? Yes. So this is the basic of osteoporosis and menopause. Decrease in estrogen is going to result in increase in the resorption of the bone, which is going to result in decreased amount of bone mineral density. So the bone is going to become weak, and it is at high risk of fractures. So since the bone is going to be weak because of the low mineral density, the most common complaint in menopausal females with osteoporosis is going to be low backache. The patient is going to have low backache. So if there is an MCQ which states that which is the most common complaint in menopausal female with osteoporosis, the answer is low backache. Is that clear? Yes. Okay. Now, what is the most common fractures in menopausal female? So the most common fractures in menopausal female in decreasing order of severity is the lumbar vertebra, the most common, followed by neck of the femur, followed by the Colles fracture. So the most common fractures in menopausal female, the most common is the lumbar vertebral fracture, followed by the neck of femur fracture, and followed by the Colles fracture. So these are more important points. Is that clear? Okay. Now, I have an image, this is an X-ray image of the lumbar vertebra, which is going to show you signs of osteoporosis. As you can see here, the vertebral disc are actually biconcave in shape. Since it is biconcave in shape, it is compared to a codfish. So since this vertebra is similar to biconcave appearance, it is compared to a codfish. So this appearance is called as codfish appearance. So codfish appearance of the lumbar vertebra is most commonly observed in case of osteoporosis. So if you take the X-ray of the lumbar vertebra in an osteoporotic female, you can find this codfish appearance or biconcave appearance of the lumbar vertebra. Is that clear? Okay. Fine. Now what is the investigation of choice? So the investigation of choice is what? Yes, the investigation of choice is dual energy X-ray absorptiometry. So what is the investigation of choice for osteoporosis? The investigation of choice for osteoporosis where there is increased risk of fracture, the investigation of choice is dual energy X-ray absorptiometry. So we know that in osteoporosis there is increased chances of fracture, and the most common fractures are the lumbar vertebra, neck of femur fractures, and the Colles fracture. And the investigation of choice to detect these fractures in menopausal female is DEXA scan. Please remember it is DEXA scan. So we'll discuss about this DEXA scan now. So the full form is that dual energy X-ray absorptiometry. So the principle of this DEXA scan is that this scan is going to use radiation source to measure the amount of calcium and further minerals which are present in the bone. So the major function is to measure the amount of calcium and the minerals which are present in the bone with the help of radiation. So the investigation of choice of osteoporosis is DEXA scan, which is dual energy X-ray absorptiometry, where the principle is that this scan is going to use the radiation to measure the amount of calcium and the other said minerals in the bone. Is that clear? Yes. Followed by measurement of bone mineral density. I told you that in osteoporotic bone, the bone mineral density is actually going to be decreased. So we can actually measure this bone mineral density. So similar to any measurement, the measurement unit of bone mineral density is gram per centimeter square. It is gram per centimeter square. The measurement unit of bone mineral density is gram per centimeter square. So in bone mineral density measurement, we have two scores with us. One is the T score and the other is the Z score. One is the T score and the other is the Z score. So T score is when you compare the bone mineral density of an old female versus a young female. So you are actually comparing the bone mineral density of an old female along with the bone mineral density of a young female. So two spectrum of females are taken from different age groups and those are compared. So you compare the bone mineral density of an old female along with the bone mineral density of a young female. So once you compare the bone mineral density, the reports will be like this, as you can see here. So as you can see in this image, anything between 0 to -1 is considered as normal. Always remember, higher values are desirable. Higher values means strong bones and lower values means weak bones. Strong bones are strong in nature and weak bones are weak in nature, and it is going to be at increased risk of fractures. Is that clear? So all these higher values are strong bones. So 0 to -1 is also strong. But -1 to -2.5, it denotes decrease in bone mineral density, which is called as osteopenia. -1 to -2.5 is osteopenia. Anything which is more than -2.5 is osteoporosis. Anything which is more than -2.5 is diagnostic of osteoporosis. Is that clear? So the osteoporosis value is anything more than -2.5 is osteoporosis. Is that clear? 0 to -1 is normal, -1 to -2.5 is decrease in bone mineral density, which is osteopenia, and anything which is more than -2.5 is osteoporosis. So what type of score are you going to take into consideration when you measure the bone mineral density in a menopausal female? It is actually T-score, because T-score is the score where you compare the bone mineral density of an old female with an young female, whereas Z-score is the score where you compare the bone mineral density of same age group people. So the same age group people are selected, and in those same age group people, the bone mineral density are usually compared. So Z-score is actually preferred for anyone who is less than 50 years of age, those females who are in the perimenopausal age group, and those who are children, and those who are in the reproductive age group. But T-score is used for those females who are more than 50 years of age, where the bone mineral density of old female is compared with that of the young female. Is that clear? Always the rule is that higher values are always desirable than the lower values, because higher values mean stronger bones and lower values means weaker bones, and weaker bones are at increased risk of fractures. Is that clear? Okay. So what are the indications to measure this bone mineral density? So in females who are more than 60 to 65 years of age, and in males who are more than 60 years of age, this bone mineral density can be measured. In addition to this, if the female has some particular risk factor for osteoporosis, such as family history of osteoporosis, history of any long-term consumption of specific drugs such as the proton pump inhibitors, some corticosteroids and anti-epileptic medications which was going to hasten this osteoporosis, if these particular risk factors are present in a female, this bone mineral density measurement can be done even earlier by around 60 years of age. Is that clear? Yes. Okay, now you tell me, what are the most common sites of measurement of this bone mineral density? So the most common sites are the hip bone, which is the femur bone, followed by the lumbar vertebra. So the hip bone, femur bone and the lumbar vertebra can be used to measure the bone mineral density. Now you may have the doubt that why hip bone and lumbar vertebra is used for the measurement of bone mineral density. The answer is that the most common fractures to happen in a menopausal age group female is the lumbar vertebra, followed by the neck of femur, followed by the Colles fracture. Since the lumbar vertebra and the neck of the femur is more common, therefore we measure the bone mineral density of the lumbar vertebra and the hip bone, that is the femur bone. Is that clear? Yes. So because of this reason, what you have to do is that in all females who have attained menopause, that is between 47 to 51 years, those females who have attained menopause, who are complaining of low backache, such symptoms, in those females you have to check the vitamin D and the calcium levels. Vitamin D and calcium levels, which are very important in the process of bone formation and bone remodeling, right? Vitamin D and calcium are very important with respect to bone. So you need to check the levels of vitamin D and calcium levels in those menopausal females who are complaining of low backache, which is the most common complaint of osteoporosis in menopausal females. If it is going to be low, you have to start the supplementation in them. So what is the recommended daily allowance of vitamin D and calcium in a menopausal age group female? So vitamin D is about 800 international units per day. and calcium recommended daily allowance is about 1200 milligram per day. So vitamin D is 800 international units per day and calcium is about 1200 milligrams per day. Is that clear? Okay. Finally, we have come to the conclusion of osteoporosis, that we'll be discussing about the management of osteoporosis. So now you tell me, what is the drug of choice for treatment of osteoporosis? So the drug of choice for treatment of osteoporosis is bisphosphonates. Bisphosphonates. So bisphosphonates are such groups of drugs which is going to result in decrease in process of bone remodeling, where it is going to decrease the resorption of the bone and it is going to result in increase in bone formation. So it is going to actually decrease the period of time of resorption of the bone. So by inhibiting the resorption of the bone, bisphosphonates are the drug of choice in the treatment of osteoporosis. So what are the groups of drugs that are bisphosphonates? These are the alendronate, pamidronate, zoledronic acid. So all these drugs are the bisphosphonate groups of drugs which is going to decrease the resorption of the bone and it is going to result in increase in bone formation. Okay, but the most common side effect of bisphosphonates is severe gastritis. It is going to result in severe gastritis and heartburn. Since the most common side effect of bisphosphonate is going to be severe gastritis and heartburn, therefore there is some prerequisites in starting this medication. You have to ask the patient to take this drug in empty stomach. The patient has to take this drugs in empty stomach with a glass full of water, and you have to ask the patient to sit upright for about 30 to 45 minutes after taking the drug. Is that clear? Ask the patient to take this drug in an empty stomach with a glass full of water and ask the patient to sit upright for about 30 to 45 minutes after taking this drug. By doing this though, this can prevent the heartburn and severe gastritis as well. Along with that, you need to advise the patient to do some lifestyle modification in order to decrease the severity of gastritis. Apart from that, before starting this group of drugs which are bisphosphonates, you have to check for the presence of any gastric ulcers and H. pylori infection being present in this patient. Is that clear? Okay. Now, what are the other drugs which are used in the management of osteoporosis? Apparently, the drug of choice is bisphosphonates. But apart from bisphosphonates, certain other drugs can also be used in the management of osteoporosis as well. So what are these drugs? So these are divided into two groups. One group acts by activating the osteoblast and the other group of drug, it acts by inhibiting the osteoclast. So basically osteoblast or those group of drugs, right, which is going to result in new bone formation, and osteoclast or those groups of drugs which is going to result in resorption of the bone. So what are the drugs which acts by activating the osteoblast? Those are two drugs which are teriparatide and strontium ranulate. Teriparatide and strontium ranulate. Strontium ranulate and teriparatide. So teriparatide is a parathyroid hormone analog and strontium ranulate is an anti-osteoporotic drug. So the major function of this drug is by activating the osteoblast, that is activating new bone formation. Right? Okay. Now what are the drugs which acts by inhibiting the osteoclast, which are the bone resorption cells? The drug is denosumab. So denosumab is a drug which will bind to the rank ligand. So if it is going to bind to the rank ligand, therefore this rank ligand can never bind to the receptors which are present on the surface of osteoclast. It will prevent the stimulation of the osteoclast and it will prevent the resorption of the bone, and it will prevent the decrease in the bone mineral density and osteoporosis. So denosumab is a group of drug which acts by inhibiting the osteoclast, which are the bone resorptive cells. Apart from that, you can also administer estrogens. Right? The major problem here is that because of decreased amount of estrogen, there is a decrease in osteoprotein protein. So the osteoprotein protein cannot bind to the rank ligand, and therefore there is stimulation of osteoclast and there is increase in resorption of the bone, which will result in decrease in bone mineral density. So therefore the problem is with decrease in amount of estrogen, you administer the estrogen through selective estrogen receptor modulator. So this selective estrogen receptor modulator is going to have positive effects at certain areas and negative effect at certain areas. That is, agonistic effect in certain areas and antagonistic effect in certain areas. So what are these drugs? These are raloxifene, tamoxifen and basidoxifene along with estrogen. Now you tell me, in previous module we discussed about basidoxifene and estrogen as a treatment of choice of which condition? Yes, it is used in the treatment of hot flashes. Basidoxifene along with estrogen is used in the treatment of hot flashes. Good. So apart from selective estrogen receptor modulator, tibolone can also be used. What is tibolone? So tibolone is basically a synthetic steroid hormone. It is a steroid synthetic hormone. So this hormone is said to have estrogenic effect, progesterogenic effect and androgenic effect. So this is one synthetic steroid hormone which is going to have estrogenic, progesterogenic and androgenic effect. So it is going to have estrogenic like effect in bone. Therefore it is going to help in decrease in amount of resorption of bone. Therefore it maintains the bone mineral density and it will prevent osteoporosis. And it is having progesterogenic action in the endometrium, where we know that the main function of progesterone is to support the uterine endometrium. And it is going to have androgenic effect. We all know that for the libido, that is sexual arousal, androgens are very important. So in order to maintain the libido, androgens are very important. This tibolone drug is going to maintain the increased libido with the help of its androgenic effect. We also know that in menopausal age group female, there is going to be decreased libido. In order to treat the decreased libido, if you administer tibolone as the treatment in osteoporosis, the androgenic action of tibolone is to increase the libido. Is that clear? Yes. So this was the treatment of osteoporosis, where the treatment of choice was bisphosphonates, but apart from bisphosphonates, all other drugs which have been mentioned here can also be used in the treatment of osteoporosis. So this is all about osteoporosis which you need to learn as a clinician, as a gynecologist, and apart from that, this is also the most important points you need to learn if you are going to give some competitive examination as well. So I hope that I made this topic very easy for you. Right? In case if you have any doubt, please write to me in the Mackler Gmail or the Instagram handle. I'll reach out to you as early as being possible. And please subscribe to this Mackler YouTube handle so that you will get the daily video updates in this Mackler YouTube handle, so that you will stay updated and you can learn as well. Right? Thank you. Please keep studying. Let's meet in